The following podcast was recorded at the ANZICS Safety and Quality Conference, July 2014. Rapid Response Teams. Imogen Mitchell asks, how do we know the call has been successful?
There should have been a call, and we don't really measure the outcome of those patients at the moment because we just don't collect those data. So I guess just to rapidly cover why we actually go out to see patients, how we might determine the success, and some of the things we measure and some of the things we don't yet, and whether these things are in fact achievable. So as you've heard multiple times today, and I'm sure yesterday, is that recognizing and responding to patient deterioration is a complex process and requires, as we've just heard earlier, team members to work together, and that the eventual outcome of the team working together is indeed successful. But of course, successful may in fact be different for different sorts of patients, because you may just think that in fact the success is a patient not dying. But in fact, sometimes that may occur, and that may be entirely appropriate. So your measure becomes different. So I guess along the way, we need to think about what it is that we do need to collect and how we determine those successes. So the role, of course, is to try and pick up the patients that actually are going to benefit from critical care support, whether it be on the ward or in the intensive care unit, such that you prevent the patient from dying from multiple organ failure. But of course, the role of the rapid response team may also be that you in fact instigate end of life as well. So it's not only averting multiple organ failure, it's just other things as well. So how do we know when we've been successful? Well, we need to work out that we have been successful, because by the looks of things, we're becoming increasingly a common event on the wards these days. Certainly when I first started out with the Merit, we had 400 calls per year at the Canberra Hospital, and as time has gone on, it's a little unclear why the numbers of METs have gone up. We're now experiencing nearly 2,000 a year, and that's only in a space of 10 years. So why is it that behaviour has changed? But we need to understand, firstly, why it's changing, but also is in fact benefiting the patient, because we're putting now an enormous number of resources into these calls. So I guess the first thing to think about, do we ever think about the patient and the family experience? And I guess as I have grown more grey hairs and older, I've started to reflect a little bit more on this. And of course, as we move down to patient-centered care, we probably need to start thinking about this more and more. Now, I may just indulge you just for 1 second, because aside my normal reputation of being an icy, still, cold kind of person, I wanted just you to close your eyes for a moment. And if those of you that smack, I'm sorry, this is a repeat. But I want to take you through a story, because I want to try and, I guess, simulate what it's like for a family member to watch something dramatic happen to their loved one. So I want you to close your eyes. I'm going to read you something out. And this is a mother writing to a surgeon, and it's about her son. And it's written, in fact, by a medical person, professor at the University of California, San Francisco. So what she writes, she says, "My son's terrible death is not something I'll ever get over, but perhaps in time it will be less painful. But I cannot get over one image, a last image that could have been different. Before I was asked to leave the room in a very rough manner, I must tell you that I saw my son was terrified, and there was no one who addressed his fear. The only person who tried was a nurse. She held my son's hand and said, 'Don't worry, it'll be all right.' Everyone else ignored him. Sure, the doctors were busy with his body. It would have been merciful if he'd been unconscious. They had important things to do. They cared only about his chest and belly, not about the little boy who was in fear. I saw no sign of the slightest bit of human kindness. My son and I were irritants. Your team would have preferred for me to be gone and for him to be quiet. Eventually they got their wish. Dr. Stone, as head of surgery, perhaps as a parent yourself, do you not feel some obligation to have your staff comfort the patient? Would the patient not be better off with less anxiety, less fright? My son's last conscious memory will be of people ignoring him. My last memory of him will be of my little boy watching in terror as his mother is escorted out of the room. It is a graven image. I will carry it to my own deathbed. the fact that people were attentive to his body, but didn't compensate for ignoring his being. So I guess it just sets a scene of what might it feel like when we ask people, the families, to leave the room. Now, I'm sure not all of you ask families to leave rooms, but I suspect quite a number do, because they sort of get in the way, because the rooms are small and it's hard to operate. But I guess I'm wondering whether, in fact, we need to measure the success in terms of family and patient experience, if appropriate. Because it's just outlined, it's daunting. Huge number of people come and appear at the door, most of whom are unknown to the patient and family. There's little communication and pastoral support. Now, again, I know there are some rapid response teams that, in fact, have pastoral care on them, but not every team. And I'm sure there are some that do speak to the patient and the family very well, but not all. And as I said, family members are often sent out of the room. So I think it is helpful to allow us to reflect more on what the patient and the family are experiencing, and maybe we can start to do that by questionnaires. But we know that it's important when looking at CPR in the emergency department, that in fact including families is good for the family, but it's also in fact doesn't affect the operations of the emergency staff. So it doesn't have a negative outcome. It helps and reassure the patient of what's going on, and it also, by assigning a staff member to allow the patients and families to know what's going on, it's a very muddling environment. And of course, it's helpful to then revisit the patient and the family and follow them up for not only clinical support, but also emotional support. So I think the first measure of success really, did the patient and family have a positive experience? And I'm just not certain that we have done much to do with that to date. So then we look at not only the experience from the patient and family, but we then look at process. Managing the patient. Were we successful in managing the patient appropriately? And there has been quite a lot of work in this area and to support what we look at. So the first thing, of course, I guess, is more of a ward environment where we, in fact, timely in getting the rapid response team to the appropriate patient. Did we, as soon as the patient triggered, was the team called? Because as we know, the more you delay, the worse the outcome. And then in terms of decision making, did we actually make the right decision at the right time? And does it mean that the patient was still triggering and therefore needing a repeat rapid response team review? And then when you look at intensive care admissions, was in fact, did we do it in a timely fashion, or was there a delay? And that delay may have been appropriate, but it may not have been. And of course, the more you delay intensive care admission, again, the worse outcome. So let's look at how we might do that. We look at ward staff in terms of the triggering, and of course you look at the rapid response team. Do we appropriately stand down the rapid response team? Was the patient trajectory appropriate, i.e. no longer triggering and no longer needing our support? Was the admission, as I say, appropriate for intensive care? And did they have appropriate end of life instigated at the time, at the right time? Was there a plan in place, and was the patient comfortable? And we've heard a little bit already about communication. Was there appropriate communication to the family and the patient, but also amongst the team? Did they actually know what was going on? Did the leader express themselves appropriately such that the rest of the team knew what the plans were? And of course, importantly, did the home team actually know what was going to be happening to their patient? Very often, I don't know what you all find, but I find that when the rapid response team arrives, the home team just disappears. So I remember being called to a surgical ward, looking at the patient and sort of saying, well, you know, who's the consultant actually looking after the patient? And I actually walked past him, not that I didn't realize it was his patient. And so I go tearing up to this consultant and say, are you interested in your patient? Rather reluctantly, he stood in the doorway. I didn't quite understand why he didn't want to come see the patient. Sort of like almost too frightened to see a sick patient. But it was really quite useful to have that conversation and hear a bit more about the patient. I'm not sure that he was that interested, sadly. So how might we measure the patient management, the process of rapid response team review? Well, first of all, I mean, Ken talked about we collect a lot of data. And I guess some of us are in a fortunate position that we actually have an opportunity to reflect on it. So we are able to collect the rapid response team review, those that had done to them in the patients, and then looking back in terms of vital signs, were they triggering before the team were called? And so if there was a delay, then that's clearly an issue for the ward that needs to be fed back to them. In terms of the rapid response team, did they make a timely admission to intensive care? Again, was there a delay? Was it more than 4 hours? Now, was this a bed issue or was this a decision issue? And I guess it's up to a panel of people to work out whether this was a decision by the team or was it in fact a crisis in beds. And then, of course, did the patient still have rapid response team triggers that in fact maybe it would have been better to bring them into intensive care at that time? Or did they then have to have a repeat call out? And is that, I guess, a measure of poor management or just the fact that that just happened to the patient? And then did the patient have appropriate treatment limitation? There was a DNR plan at the end of the rapid response team review with a good end-of-life plan. And so Chris Zuber in Wales has looked at the outcomes of rapid response team reviews and looked at them in terms of a positive outcome or a negative outcome. And I guess it really just reiterates what I've just said. So a positive one would be that they had timely admission to intensive care, that they were no longer triggering on the ward in terms of the MET triggers, that if they had died with a terminal care plan. And other factors to look at is whether they had an end-of-life plan at the end of your rapid response team review, that if they were triggering, it was for a new disease, not the current, and that if they were triggering, was it just a chronic condition that they were triggering for? And of course, the positive outcome that they did in fact leave hospital alive. So that's really looking at the success of, and then they put a nice little speedometer to depict how successful their MET reviews have been. So I've talked a little bit about the patient and family experience, the process measures in terms of management, and of course, importantly, we do need to reflect upon patient outcome. It gets a little bit confusing when we look at patient outcome because I often see people counting patients twice. That is, that the patient dies twice. And that's when it becomes difficult to decide, do you look at the first MET review or the third MET review? You need to work out what you're going to do and what you do systematically every single time. But of course, when you go to the literature, probably everyone's doing it slightly differently. You don't quite know how everyone else is doing it. But whatever you do, please just make sure that patients only died once. Now, you can look at the initial outcome, of course, right at the end of the rapid response team review. Or you can look at it just as those patients have had multiple reviews and look again just once. You could look at after 24 hours, and in that 24 hours you can see whether they've actually been admitted to intensive care unit in a timely fashion, or what the actual outcome at the end of 24 hours in terms of patient alive or dead. You could also look at a cohort of patients that have gone to intensive care unit. And certainly over time, I've certainly seen in Canberra that our number of admissions coming in through a MET review versus just a normal ward review has more than doubled. So, I don't know, 6 years ago, 30% of our patients come to intensive care unit from the ward were from a MET review. Now it's 70%. So something has changed in terms of behaviour, either through the rapid response team review or, in fact, the behaviour on the wards. And then ideally, of course, we would like to look at quality of life after a rapid response team review, which I'm not sure that many people, if any, have done. Now, I've just taken some data in terms of patient outcome and some measures and tried to compare. So this is the Great Austin Hospital sitting in Melbourne. And of course, again, I probably haven't interpreted it correctly, so I apologise, Daryl. But it's just to show, so this is Canberra over, I think, a 18-month period, and Melbourne, I think, over 5 years. But it's just, and if you look at the percentages, you can see how we do things slightly differently. But does that mean that Canberra's worse than the Austin? And again, until we get a really clear data dictionary, it's really going to be hard to compare each other. So if you like, in Canberra, 60% of patients will remain on the ward at the time of the first MET review. Similar at the Austin. But you can see that those going to intensive care unit, the first MET review is higher in Canberra than it is in the Austin. However, after a 24-hour period, they then become very similar at 20%. Because does that mean that they should have gone there in the first place and that patients are not benefiting if they have a delayed admission? And again, it's hard to know at the end of the day how we compare in terms of mortality, because the one paper that's been quoted didn't actually state the mortality, just removed all patients that had limited or end-of-life care. So I guess what I'm just trying to say, yes, you can collect data, but it's very hard to compare it. But it's important, at least in your own institution, to compare over time. So, in conclusion, I do think that we need to collect patient and family experience, how they feeling, whether it's a successful outcome or not. We need to measure the process, and we need a strict data dictionary, which I think we probably need to do more work on. We need to measure over time, and certainly John and his group have done that very nicely, as indeed have others around the country. And we talked a little earlier about team satisfaction and reflecting on one's own opinion as to whether we did a good job or not. And that's both from a ward perspective and a rapid response team perspective, as was said earlier. And of course, we do need to look at patient outcome, because we're pouring a lot of resources, and if it's really not benefiting our patients, both from their experience in terms of alive or dead, then we would need to reflect. And again, as I said previously, feedback needs to go to teams and the ward in terms of where we can improve. Thank you.
For more podcasts from ANZICS, go to anzics.com.au.